welcome to our very first episode of Ask Physio Éireann Live.
Oh, to the camera.
Yes, we're good. I think so. So, we are hoping some people will tune in to watch us at 8:30 this evening. Great, yeah, I think that's it off and yeah, perfect. So, as I said, we've decided to do our Ask Physio Éireann Live to see if we can help anyone out there if they have any questions or anything that they'd like us to help them with from their physiotherapy point of view. So we put up a post during the week, and what we want you to do, if you have any questions for us, to just go into the comments box and type in your questions. And if you don't actually want people to see your name and you want to send us something anonymously, or you have any questions that might be a bit more personal, you can actually send us a private message on our Physio Éireann Facebook page, because we have that open beside us. So if there's anything at all that we can help with, just ask. So we put up the post yesterday and we have already had a few questions through, so we're going to kick it off with one of them.
Do you want me to put it up?
Yeah, just pull it up. It was about frozen shoulder, I think.
Yeah, so the question is, I have a frozen shoulder and have been told I should have a steroid injection. Would you recommend it?
Okay, so frozen shoulders. Well, let's just go back a little bit and keep commenting if you have any questions, and we'll come through them as we go through. So let's just go back a little bit and talk about what frozen shoulder is, and then we can go through what the treatment options are and see if we think a steroid injection is worth doing. So a frozen shoulder, as it sounds, is to do with shoulder pain. Usually people come into us with frozen shoulder that is of gradual onset. So there's actually two types. There's what we would call a primary frozen shoulder and a secondary frozen shoulder. So a primary frozen shoulder is one that happens for no reason, insidious onset. Patients will come in and say they can't really identify why their pain started. Usually the pain is sort of at the top of the shoulder and can refer down a little bit.
And who would you say is most common in frozen shoulders?
Well, from the studies and that, we know that it's most common in those between 40 and 60 years of age, and a little bit more common in women than men. It is definitely related to people with diabetes. So 3 to 5% of us have a risk of getting frozen shoulder, but if you have diabetes, you're 20% likely to get frozen shoulder compared to the normal population.
And what if you've had frozen shoulder? And what's the risk of developing it again?
I don't know if you want to hear this, because if you've got frozen shoulder, it's not great.
Oh yeah, okay. But if they've already had it in the past, they might want to know.
We see this a lot. So someone will have developed one frozen shoulder, and then there's actually a 20% chance that you'll start to get symptoms on the other side. We don't know why either. It goes through a few different stages we'll talk about, but what actually happens with frozen shoulder is the tissue that connects our bones together, the joint capsule and ligaments, they, for some reason that we don't know, they start to, we think there's a little bit of an inflammatory process at the start, and it triggers contractures of that joint capsule, and it tightens the capsule. So that's the tissues that connect the bones together, not to do with the muscles. The capsule tightens, and then that restricts shoulder movement. So at home, if you think you have frozen shoulder, there's a few signs and symptoms. The first thing is pain, obviously, around the shoulder. It usually doesn't go below the elbow, but can come down the arm. The second thing is that you've lost joint range of movement. So some people have problems with their shoulders where if they lift their arm up, it's sore, and therefore they don't lift it up over their head. If you have a frozen shoulder, usually you will lose range no matter whether you try to move the arm or not. Regardless of pain, you cannot get your arm usually up over your head. First thing that happens is, I don't know if you can see this in the camera, but you lose rotation. So you can't move your arm outwards. If you compare it to the other side, one will move out nicely, the other will be really, really stiff. And that's one of the first clinical signs we look for in clinic. The second thing then is when you move the arm off to the side, you usually can't get it past 90 degrees. Same thing up in front. So a true frozen shoulder, no matter how hard you pull with the other arm, you won't move it up. And in terms then of what are the symptoms people say, so commonly people will notice that they can't move, like putting on their clothes,
Yeah, putting a hand
behind their back,
big one.
up overhead, trying to brush the back of their hair.
Night pain, lying down.
Yeah,
night
absolutely.
One of the biggest ones, I would say.
And that's why they often come in, because they're not sleeping at night, particularly if they lie on the affected side. It's waking them up at night time.
So what would they do? What would you suggest if someone had a frozen shoulder?
Okay, so in terms...
We'll come back to the question. The question is
Yeah,
about
sorry,
injection.
we're getting way off cue here. In terms of treatment for frozen shoulder, so It's tricky. This condition has been going around for a while. We know what it presents with clinically, but how do we treat it? A first off, conservative management approach, physiotherapy is definitely worth a go. In clinic, we would give people, if we think about the phases of it, so the initial phase is usually pain, and then it'll start to get stiff, and then towards the end, the pain will reduce a little bit, but the arm will be really, really stiff. And in the last phase, it will tend to start to resolve itself. So in that initial painful stage, from a physiotherapy viewpoint, we will try to keep the range of movement. So when patients come into us with frozen shoulder, we will start them on exercises to maintain their movement. So things like using the other hand to lift it up overhead. We often do stuff with a broomstick or a golf club to get that arm movement, to try and maintain the range they have and try and improve range as much as we can.
So movement, then what?
This is where the steroid injection comes in. If, we've tried a few sessions of physio and that patient still isn't sleeping at night, then that's probably when I would consider talking about a steroid injection. What do you think?
Yeah, if they've tried anti-inflammatories, a regular course, not just one every now and again, if they've taken them regularly, if they can.
What you would talk to your doctor about,
yes,
this is not something you do off your own bat, you would speak to your GP about pain relief first. Yeah.
And if you're taking adequate pain relief and it's still not having an effect, then I would go down the route of steroid injection. But as far as the steroid injection goes to improving function and improving, speeding up the recovery, there's not much evidence to support the steroid injection. I would be just doing that to ease symptoms and ease pain.
I would agree. We would use it for patients that are not sleeping at night and we're not managing to settle that, or if they can't do their exercise because it's so sore. So you're using it as a usually it gives short-term pain relief, if we're honest here. If you're lucky, a steroid injection will give you short-term pain relief. It's very rare that a steroid injection will resolve your frozen shoulder.
And let's go a step further. So we'll say this person had the injection and it hasn't worked, and then they've been suggested, which a lot of people have, a manipulation under anaesthetic.
Yeah, so
just what is that?
And there is other treatment options, and this is where it escalates for sort of a frozen shoulder. If you're doing your physio and it's not improving it and you're still in a lot of pain, where does that leave you with treatment options? Well, steroid injection probably is our first protocol. It may be worth a go to see if it helps. Then we would look at, and again the research here is, it's not telling us we should be doing this. Like, there is options like hydrodilation, isn't it? Hydrodilation.
Again.
That's where they take anaesthetic and they inject it into the joint capsule to try and stretch the joint capsule. But the research shows that the outcomes at 6 and 12 months are no better than physio alone. And then manipulation under anaesthetic. This is where they knock you out and they put you to sleep. Sorry. They put you to sleep. In other words, you can't feel anything, and the surgeon then takes your arm and gently tries to move it through range as best they can.
I wouldn't say gently.
Okay. We don't know, like, some people might have had it and some people have found that it has improved range.
Yeah, comment if you've had it actually. Yeah, let us know if you've had it and what you've thought of it.
And then manipulation under anaesthetic. It has got more risk than the hydrodilation because they can actually tear the tissue while they're doing it, and the patient can be in an awful lot of pain after. Sometimes it might improve range, sometimes it may not. But if a patient is really struggling and they're not coping with their symptoms, these are the options that are before them. But you would try conservative management first. You talk to your GP, your healthcare professional, to refer you on to a specialist to ask them those questions. The other option then is the release, arthroscopic release.
Yeah.
So this is where you do a small surgery, a keyhole surgery, to go in and actually cut the soft tissue that it has the contractures in it that's causing the stiffness. And the studies on this too are still, we're not sure. We're not sure whether we should be sending our patients for this or not. There is some stuff that says it can improve range. Don't know, you could go through the arthroscopic procedure and not have any improvement afterwards. So it's a really tricky one to manage. I think going back to just sort of the physio viewpoint on this, for my patients, and Ollie, you can put in your 10 minutes here, if somebody comes in with a true frozen shoulder, I get them first of all straight away onto their exercises to maintain range of movement. I will try a course of manipulating the shoulder, mobilizations on the shoulder, but if after 4 sessions I'm really not seeing any improvement, then and that patient's pain is manageable, so they're sleeping at night, they're managing their activities pretty good, I will tell them, keep going with their exercises, and really just discharge them from care. They can get back to me if they need it, because we do know that these shoulders do resolve over time. Some people can get quicker better with physio, but if they're not responding, we just let them go, continue their exercises. That's for those that are coping with their pain levels. If you're not coping with your pain levels, then we will discuss things like steroid injections.
Okay, that's enough about that. Someone's posted in a private message, and they've asked that they have knee osteoarthritis, but they don't feel they're ready.
The surgery.
They don't feel they're ready for a total knee replacement yet. Would there be any other options with regards to maybe keyhole surgery? Would that be for them?
Okay.
Or what?
I wonder, the person's asking, they have knee osteoarthritis. Let's assume that this person has gone to a consultant, and the consultant has recommended surgery for their type of arthritis, and they don't want to have the total knee replacement, and they're asking if the keyhole surgery is an option. So a keyhole surgery, known as a knee arthroscopy, is where they go in with a camera and then a scope to clean out the knee. They usually take away any bits of cartilage in there that might be causing problems. But I would have to say, from an evidence-based point of view, we now know that we should not be recommending scopes for degenerative knee osteoarthritis. That the long term, and really you're not even talking long term, you're talking 12, 18 months down the line, that knee is no better than it would be if you didn't do it, or if you just did conservative management. What's your view?
No, I completely agree in that the evidence does not support keyhole surgery for osteoarthritis of the knee. But what I would say is that total knee replacement, depending on what age you're at, isn't the worst thing in the world if you're suffering with it, if you're quite stiff, if you're quite sore, and it's just really limiting your activities that you'd normally do. I wouldn't hesitate. I would go, have it done, so you can get back to doing your activities of daily living, on your normal golf, your walking the dog or anything, be able to do that for longer, as opposed to dwindling down your activity levels over the next few years, and then deciding then you're ready for it, when in actual fact your life has narrowed down because you've just been too sore and too stiff.
I would say, many of our clients are obviously based in Donegal, and I would say there is a general consensus in Donegal that people want to avoid major surgery for as long as possible. And like when we came back, we would see osteoarthritic knees come in that really should have been operated on a few years previous to that, because people are so apprehensive about the surgery. Now, don't get me wrong, yes, it's major orthopedic surgery and it's going to take time to recover, but as Ollie said, it's about a way up between quality of life, isn't it? Like, if you're coping with your knee fine and you're doing the things that you want to do, fine. But if it's stopping you from playing with your grandkids or doing the dancing that you want to do, you really have to take a step back and look and weigh up, is this knee limiting me? And we would say, to our patients, if the answer to that is yes, go and get it done.
Or go and see a consultant.
Go and see a consultant, yeah.
But it's not the biggest thing in the world.
It's not, and we would find that the most apprehensive patients that really were trying to avoid it, when they came back to us afterwards for their post-op rehab, they were like, why did I not do this years ago? And if the other knee starts to give them bother, they do it without hesitation. So I think people hear the worst stories, but actually these surgeries now are routine, and the outcomes are good for most people. So, I suppose going back to the question, would I recommend to a patient of mine to have a knee scope done for osteoarthritis of the knee? The answer is no, because I know the long-term outcomes are no better than actually if they just stick to the rehab.
Yeah. Just on a side note, I know the person didn't ask, what's your opinion on knee scopes in general? When are they indicated? So are you completely against knee scopes?
Well, the research on this is really interesting, because they're really saying that should we be doing these knee scopes at all, but I would say I definitely recognise the type of patient where it's beneficial. So this is my experience anyway, if I have a younger patient, so say, this is a dangerous moment, if I have a patient who is fit, active, and probably under 45, and they've had an incident or injury where they've had a meniscal tear. So what we're talking about here is, within our knee we have two big chunks of cartilage that we call meniscus. You can Google it in an extra tab if you want to see what I'm talking about. And so I would say without giving away any patient information, a standard case would be someone who came in, they might have got down on the floor to pick up something, or they twisted their knee, or they were out running and they did like a rough 10k and they felt their knee afterwards, and we've sent them off for an MRI and it confirms a meniscal tear, but the knee is in good shape. I would say that there's no degenerative changes in that knee, there's no osteoarthritis, just a simple meniscal tear. Now, I'm not sending that person off to the surgeon. That person, I'm going to say, look, we have a meniscal tear here, let's rehab it.
For how long? How long did you give it?
I want to see improvement within 6 weeks, but I don't want a better knee in 6 weeks. I want to see improvement. So I want to see pain going down, I want to see their range of movement improving, that they can do their daily activities. They might be back to running, but that things are going in the right direction. If after a month and a half and they've really stuck to their rehab plan and that knee is getting no better, it's still intermittently swelling on them, they can't get up and down the stairs, then I would refer that patient to an orthopedic consultant for their opinion on whether they should have a scope to clear the meniscus.
Okay.
And I would have to say, most of the surgeons we work with, they'll send them back to us if they haven't done the rehab, because we know that the studies show that in most cases, a good rehab plan, the knee will come around by itself. And so now we will only send them to the surgeon after they've failed rehab. And thankfully, lots of them respond really, really well. So, yeah, what about your thoughts on that, knee scopes and when it's appropriate or not?
I completely agree. Any meniscal tears that have failed conservative rehab, or sometimes there's just some people that have just such a big tear that you know that they're not going to get on with conservative rehab, then we will send them straight. But the majority of meniscal tears that we would see, we would try and rehab for 6 weeks, and I would probably say 50-50. Some 50% would all the symptoms settle down, and 50% would end up going on a referral to the consultant for further surgery. So knee scopes aren't bad.
It's knee scopes for degenerative arthritis, for real osteoarthritic knees that really are candidates for total knee replacement. Scoping them is not going to buy you much time. Good, so we've had, so there's some of you watching, any questions, do let us know. We've had another one in privately, so we won't mention any names. So again, if you don't want your name mentioned or you don't want to put it up public, you just send it private. So someone has asked here, can someone that broke their ankle years ago benefit from physio now? Sometimes the ankle swells up and is awfully painful.
If you've broken it, the likelihood is that you will probably onset degeneration in that joint a little bit earlier than what would have happened if you didn't break it, obviously. So you will have some degenerative change there that will probably give you pain, and treatment alone probably won't affect too much of the joint pain itself. But
well, I don't know, because
around it, so the soft tissues you can definitely have an effect on in terms of releasing the calf or doing some calf stretches, having a look at the strength, because a lot of the time we see people come out of casts and things and didn't do any stretching, didn't do any strengthening, and we're just told to just go about their normal life, and their ankle or their calf would strengthen itself back up, which it doesn't happen. A simple way to check, actually, so I would always say, how much rehab have you done before? Have you done your exercises? Did you go through your rehab after you broke it? Did you get the power in that ankle back? I don't think they ever get 100% compared to the other side, but I would expect 80%. Yeah.
Would you say? Depending on the break is all he said. Like what Ollie was talking about there, so we don't want to panic people to think that, you know, if they've had a break that they have arthritis. But if you do have a trauma, particularly a break, then you are likely to get those changes in a joint earlier than if you didn't break that ankle. But it doesn't necessarily mean that you have to have a tolerant pain in it. So a simple way to check for an ankle, I think, as to whether rehab will help or not, is a simple heel raise test for me. So if you stand on your good leg, lift your affected leg off the floor, can you go up and down on your tiptoes? How many times can you do it? So a heel raise test. Usually on a good leg you should be able to do it, you know, and it should give you no bother, up and down, no problem. And then compare that to the affected side. Can you get your heel off the floor? Are you struggling after 5 or 6 reps? If the answer to that is yes, then you definitely can benefit from strengthening that ankle.
Which will help cushion and protect that joint a little bit more, so it won't be as sore and as painful.
So we can't affect the joint itself with this change there, but we sure can get the muscles around that ankle strengthened up. And the other thing that we do in these cases is we strengthen further up the leg. So the stronger your hip is, the stronger your knee is, the less force that goes through that affected ankle and the less pain. I definitely have worked with patients who had fractures even as far back as 10, 15 years ago, who have come into me since we opened up in Donegal, and I definitely can't make their ankle as beautiful as the other one, but we definitely get them doing the things that they want to do. Like often I see ladies come in who want to wear a heel for an event and they just can't tolerate it, and then I work with them and grade their strength back up, and we start doing things like practicing wearing heels up and down the hall to try and strengthen the ankle so that they can tolerate more load through it. And I think that's the key. If we strengthen it, then changes can happen.
I would just try and find a better shoe, really. Just something that looks average.
Sometimes
but
girls
doesn't
need
have a
their
heel.
heel, Molly.
No,
Sometimes they need their heel.
no, it's not worth it. Perfect.
I might not always agree here on a half Physio Éireann.
On a Saturday night.
Oh my god, that was quite half an hour. Okay, I think that's the first one. So what did we cover? We
A
covered.
few more questions that we can get. So we can get them in the next.
Oh, there
next
is.
session.
Sorry. Well, we don't know how it went down. We hope you enjoyed the information. We talked a little bit about frozen shoulder, scopes for arthritis and meniscal tears, and then a little bit on
total knee replacement.
total knee
And
replacement.
a little bit on fractures and ankles.
rehab after fractures, which you can always get stronger. So
What we're going to do it again, do you reckon?
I don't know. What do you think? Well, people found the information helpful.
We'll give it another go, I think. Next week sometime.
Yeah, stay tuned, and we will get to those questions that we didn't get to. There's one about ACL rehab there and total hip replacement. So we will get back to those next week. We'll put up a post during the week to see when we'll do it again. So I think that's all we do.
Yeah. Thanks for watching.
Thank you for watching Ask Physio Éireann live.
Cheers, guys.
Bye. Have a good weekend.